So there's been an explosion of interest in this topic. The knowledge that has resulted, the information, doesn't necessarily translate into immediate things that we can do, but I think the roadmap for where we're going with patients with sleep apnea is increasingly becoming more and more clear. And I'd like to share that with you. So first of all, what do we mean by sleep-disordered breathing? Well, sleep-disordered breathing, even if a patient doesn't have known sleep apnea, can occur after certain types of anesthesia and surgery. And patients, even if they don't have sleep apnea, are at risk for postoperative sleep disturbances, including apneas and desaturations. And this has been known for a very long time. The connection between what was observed, these apneas and desaturations in the post-anesthesia care unit, wasn't immediately connected with the resemblance to obstructive sleep apnea, but it's now apparent. And clearly patients with obstructive sleep apnea are at risk for worsening of their own disease. So this table is taken from a study that's now older, but again, a relatively simple study. They took individuals who had varying histories of snoring, including people who were not known to snore, all the way up to people who were heavy snorers. And then they looked and just observed what they did postoperatively. And you can see that even patients who did not snore preoperatively, 25% of the time of their sleep postoperatively, they were snoring. And individuals who were heavy snorers pre-op snorted even more. And you can see also that individuals who were not known to snore preoperatively had periods of apnea and desaturation, and individuals who were heavy snorers had even more of these episodes. So again, sleep-disordered breathing can occur even in individuals who are not known to have sleep apnea. Now, what do we mean by sleep apnea? Sleep apnea, as I've listed here, is a syndrome consisting of either of periodic, partial, or complete obstruction of the upper airway. There's an arousal response. The individual becomes awake enough to restore airway patency, and this cycle occurs dozens, hundreds of times a night. There's associated daytime sleepiness in people who have sleep apnea, and these episodic desaturations and episodic hypercarbia can lead to cardiovascular disease. Now, it's very important for us to talk about what controls the upper airway's patency, because this is at the core of the issue with patients with sleep apnea. So basically, there's three things that control upper airway patency. The first, and very important, is when an individual breathes in, a negative pressure develops in the airway, and that's because in order for air to move from or outside the patient, atmospheric pressure, into the lungs, a negative pressure needs to occur. That occurs usually in spontaneously breathing individuals by changes in your pleural pressure, and air is drawn inside, but there is a negative pressure in the airway. Also, the airway anatomy, that is, its shape and size, is very important. A second major controlling factor is how the nervous system compensates for this negative pressure in the airway, and there are muscles whose function is to resist collapse of the airway, and by this active muscle tone, maintain airway patency. And the final factor is ventilatory control, how the central nervous system and the chemoreceptors and whatnot respond to issues of airway obstruction, changes in PO2 and PCO2. And all three of these issues have been implicated in the pathogenesis of sleep apnea. And the reason I'm mentioning it is all three of these can be impacted by perioperative interventions, as you'll see in a moment. So the pharynx is collapsible. Soft tissues and bony structures can increase the tissue pressure that's surrounding the airway and predispose to the pharynx collapsing. And if you have obesity or big tonsils, etc., you can have more of this external tissue pressure that causes the airway to collapse. And we do know that anatomic differences in the upper airway distinguish individuals who have sleep apnea from those who don't. So here's a cartoon in three sort of conditions. The first one at the top that's listed normal is a normal amount of soft tissue within a normal size bony enclosure leads to a normal airway size. Now, if you try and stuff more fatty tissue or big tonsils or whatnot into the same size bony enclosure, you'll have a decreased airway size as listed in the middle category. And conversely, if you have a regular amount of tissue, but it's trying to be stuffed within a smaller bony enclosure, someone with micrognathia, for example, again, you can have a small airway. And here's an illustration of what an airway might look like. It's a 3D reconstruction from CAT scans. An individual who does not have sleep apnea on the right side labeled normal, and an individual with sleep apnea on the left. And you can see two areas that are identified, RP for retropharyngeal and retroglossal. And you can see the retropharyngeal airway is much narrower in the individual with sleep apnea than it is in the normal individual. And although it's not as obvious, the same is true for the retroglossal region. Now, I mentioned these other factors that impact the control of airway patency. And another one is these neuromuscular factors, because we know that differences between the anatomy of the upper airway is not sufficient to explain sleep apnea in all patients. And again, muscle activity is very important. There are muscles that have to have active tone to help maintain airway patency by resisting collapse of the upper airway. And there clearly are differences in individuals in their ability to compensate for abnormal anatomy or to compensate for changes in pressure in the airway. And anesthetics do affect muscle tone and neural compensation for these anatomic loads. So this is a complicated slide, but I put it here as a reminder for me to tell you that if you stimulate the hypoglossal nerve in anesthetized patients, you can help relieve airway obstruction. And basically what you see here is that when the hypoglossal nerve was stimulated, the amount of peak flow increased significantly in individuals who previously had flow limitation from their sleep apnea. Now, so this makes 2 points. Number one, neural control of the airway is very important in either the development of sleep apnea or potentially not developing sleep apnea, and it also points a way forward to potential treatment. Now, a nerve stimulation of the hypoglossal nerve is not a pleasant thing, and that's why these studies were done on anesthetized patients. But when I said at the beginning that we're starting to see the direction where we're going to go, I think this is one of the things that we may see in the future, some sort of nerve stimulation to the muscles of the upper airway and pharynx to try and maintain airway patency. Our cartoon, again, to illustrate the issues that affect airway collapse. On the left, issues that promote airway collapse, negative pressure when you breathe in, extraluminal pressure around the airway, say from excessive fat or a small mandible, promotion of airway patency, these pharyngeal dilator muscles. And it is possible to quantitate the ability of the muscles in the upper airway or the integrated system to resist airway collapse, and I'm not going to go into it, except that I put this slide here because I'm going to show you in a few minutes where the investigators did quantitate this. But basically, think of this as a scale, a balance scale, and you can see upper airway mechanical loads, so a narrow airway. This is going to tend to push the scale up in the direction of apnea. On the other hand, there are forces that resist airway collapse, and what's listed as compensatory neuromuscular responses, and these are going to pull the balance scale down and maintain a patent airway. And it is possible to quantitate this by putting a negative pressure on the airway and determining the point at which airway collapse occurs, and that gives you a number that you can become quantitative and objective about this issue. So again, just to summarize, putting it all together, a small upper airway, either too much adipose tissue or a small enclosure. When a person is awake, there's active muscles that resist airway collapse. When the individual falls asleep, this reflex activation of the muscles to maintain patency may be lost or attenuated. Airway obstruction occurs. Snoring is from turbulent flow in the airway. Hypoxia and hypercarbia occur. There's a stimulatory response. The patient arouses enough to regain airway patency. Rinse and repeat thousands of times or hundreds of times a night. And this, again, is a cartoon. I put it in here mainly a very nice editorial in the American Journal of Respiratory and Critical Care Medicine talking about the pathophysiology of sleep apnea, and again, talking about this vicious cycle that occurs with repetitive airway collapse and regaining of patency. All right, let's turn our attention. Is this what you think of when you think of a patient with sleep apnea? You know, this is Fat Joe from the Pickwick Papers. Well, here's the problem with this. The problem is that whatever stereotype we have in our mind is wrong, okay? Sleep apnea is very common. Across all comers, 4% of middle-aged people meet the criteria for sleep apnea. Sleep apnea is clearly more common in older patients and obese patients, but you don't have to be older or obese to have sleep apnea. It's very common as patients get above 65 years old, and I'll show you an illustration of that in just a minute. Someone did a study of commercial truck drivers. Almost half of them have sleep apnea. So when you're driving home, maybe you can increase the distance behind that truck driver. 14% of NFL players have sleep apnea. Now, you may not be surprised by that. Some of those football players are big individuals and have big necks. My point was, sleep apnea can be anywhere, even in an individual that looks, quote, looks healthy. Sleep apnea patients have a large increase in mortality, probably conservatively contributes to more than 40,000 excess deaths in the US. This table, taken from an article a few years ago in JAMA, they just did a survey of patients' prevalence of sleep apnea, Wisconsin state employees, southern Pennsylvania households. And all I want you to see is that as individuals move from the 30s to the 40s and 50s to the 60s and beyond, the incidence of sleep apnea increases very significantly in both men and women. Here's another study. I did it a little bit for levity, but a little bit to illustrate a point. So someone did a study of consumption of caffeinated sodas, and they found a correlation between the more sodas you drink and the likelihood that you'll have sleep apnea. So for all of you like me that thought drinking Diet Pepsi was relatively innocuous, maybe not so. And it's also an illustration of, again, the explosion of interest in sleep apnea, and people are looking at all sorts of connections and correlations and discovering things that were previously unsuspected. Sleep apnea has a number of associated diseases. There's cardiovascular disease. People have fatigue, memory problems. They fall asleep at inappropriate times, perhaps during a lecture by Dr. Rock. There's a higher rate of accidents at work or driving. Many of these patients have hypertension. In fact, hypertension is one of the screening criteria that we'll talk about shortly. There can be arrhythmias, a contribution to coronary disease and stroke, an increased incidence of reflux, etc. Now, this slide, again, I don't expect you to be able to read the table, but what these investigators did was something very interesting. They looked at elderly women over 65 years old who had normal cognitive function. They performed sleep studies periodically over at least 5 years. And what they found is that these older women who developed sleep apnea had a 2 times incidence of developing cognitive impairment. So again, it points out the associated illnesses that accompany sleep apnea, and again, would illustrate the importance of diagnosis and treatment individuals. They've looked at sleep apnea in police. I've highlighted a couple of things. Police with diagnosed sleep apnea are more likely to be injured on work. They're more likely to have complaints made about them by citizens, and they're more likely to have fallen asleep while driving a car and stopped in traffic. So again, a very significant issue across the board. We know that if an individual's sleep apnea is treated, their health usually improves. Certainly daytime sleepiness improves, the number of accidents at work or driving goes down significantly, hypertension improves, CPAP treatment of sleep apnea improves hyperglycemia, not known whether it decreases the stroke risk, and certainly not yet known whether it decreases the risk of perioperative complications. This table, taken from a New England Journal article a couple of years ago, looking at the effect of CPAP treatment of sleep apnea on the metabolic syndrome, and basically CPAP was very effective in reducing and reversing metabolic syndrome, decreasing diastolic blood pressure, decreasing lipids, cholesterol, triglycerides, etc. How do we diagnose sleep apnea? Again, I think the first thing is to think about it. The sensitivity of a clinical diagnosis is low. It's not great. There are some things we're going to talk about that suggest sleep apnea: daytime somnolence, snoring, a BMI greater than 35, a neck circumference greater than 17 inches. This is the point at which a lot of guys in the audience start going like this to feel their neck. and certainly whether individuals have been observed to stop breathing during sleep. And the main thing is to think of sleep apnea even if the patient otherwise seems healthy. The gold standard, of course, is polysomnography, a sleep study. Now, a questionnaire of sorts has been suggested called the stop-bang criteria, which you are probably or may be familiar with. 8 relatively simple questions. Does the individual snore? Does the individual have daytime fatigue? Have they been observed to stop breathing? Do they have hypertension? Is their BMI greater than 35? Their age greater than 50? Neck circumference 40 centimeters or 17 inches? And are they a man or a woman? Male being the at-risk group. And the more of these stop-bang criteria you have, the more likely you are to have sleep apnea on a screening study. Some people suggest you only need to have 3 of these criteria, but certainly the more of them you have, the more suggestive sleep apnea is as a possibility. Francis Chung, who writes a lot about sleep apnea, has also done a nice study showing that if you have an elevated bicarb, it can significantly increase the sensitivity of this so-called stop-bang questionnaire. So it's another thing to keep in mind. As your bicarb goes from 26 to 28, you can see the increase in specificity, and either mild, moderate, or severe sleep apnea goes up quite dramatically. We know that one of the mainstays of treatment is CPAP, or positive airway pressure. Again, it acts as a pneumatic splint. When we started out, we talked about how negative pressure develops in the airway and promotes collapse. CPAP puts a positive pressure on that airway and resists the tendency to collapse. The key thing to keep, couple of key things to keep in mind. First of all, you can't just slap a CPAP mask on someone. Even in sleep labs, some titration of the amount of CPAP is necessary to be effective. And another thing is, don't just ask a patient whether they have a CPAP mask, because they'll probably say yes. The real question is, do you use your CPAP mask? And probably about half of them will say no. They keep it in a closet, it's uncomfortable, it's unpleasant, it's noisy, whatever. So it's not just whether you have it, it's whether you use your CPAP. And I would contend that the thinking that sometimes is part of our perioperative world that, well, so what if the patient has sleep apnea? We'll just put a CPAP mask on them postoperatively. That may not be the way to go. Sleep apnea is very common in surgical populations. Again, Francis Chung, a couple of years ago, looked at a variety of surgical populations, including general surgery patients, patients having epilepsy surgery, bariatric surgery, and found a very significant proportion of patients, you can see, ranging from 10% to like 70%. And here's another concerning thing. We're not good as perioperative clinicians in diagnosing sleep apnea. So Singh and colleagues just last year published a study looking at whether surgeons and anesthetists were able to diagnose or had diagnosed sleep apnea. And as you can see, although there was a difference between surgeons and anesthetists in their ability to detect sleep apnea, the main point is neither group was particularly good. So we're undoubtedly bringing many patients to the operating room with undiagnosed sleep apnea. Now, I started off the talk by saying the roadmap in terms of how we manage these patients is starting to become more clear. And one of the things that is becoming evident, although again I can't provide you with complete evidence-based reasoning on this account, is that there are differences in anesthetic agents in how they affect upper airway collapsibility. So you may remember a few slides ago I showed you a balance scale where there was the ability of the neural compensatory responses to overcome the tendency to collapse and how you could quantitate that. So here is the same sort of example where individuals were anesthetized with either halothane, of course no one uses halothane anymore, but sevoflurane. But the main thing is 2 different inhaled anesthetics. Very significant differences between these 2 anesthetics in the point at which airway collapse occurred. Individuals with sevoflurane were much more susceptible to airway collapse than individuals who received halothane. Now, I'm not here to say turn the clock back 30 years, give everyone halothane. I'm here to say that we are learning more about how anesthetic agents can affect airway collapse, and an anesthetic is just not an anesthetic. And another thing is it appears that there may be a dose-response characteristics in terms of how anesthetics affect the airway. So here are slices of CT scans taken at 3 different levels: SP, soft palate, BT, base of tongue, TE, tip of epiglottis, that's going from top to bottom, going from left to right, 3 different concentrations of sevoflurane. For those of you who don't give sevoflurane, a low amount, a medium amount, and a higher amount approaching an anesthetic level. And although it may be hard to see, you can see at the individuals who are receiving the low amount of halothane, where the arrows are pointing to is the airway, and you can actually see the airway. If you look all the way to the right at the highest concentration of sevo, it's almost very hard to see the airway. So a dose-response characteristic of inhaled anesthetics. So again, suggesting that in the future, we may be able to modulate how we anesthetize patients to try and prevent this sort of airway collapsibility. We know that if you just anesthetize an individual, the impact on their sleep is minimal. There is clearly an interaction between surgical interventions, anesthetic interventions, the postoperative state, perhaps the use of opioids, that all interact in some way to produce airway collapse. Now, I want to spend a few minutes talking about whether sleep apnea causes complications in patients after surgery, because this is really a key issue. And there are a number of studies. Yesterday, I presented a couple of studies, one saying there were more complications, another study saying we couldn't find any. I'm going to show you a few more. Wang and Chest a few years ago looked at sleep apnea, and basically they found patients with sleep apnea were more likely to have a potpourri of complications, such as respiratory complications or GI complications. Not particularly striking, but this is what they found. Lau, in the Canadian Journal of Anesthesia a couple of years ago, found more interventions were needed in sleep apnea patients, like they needed more supplemental oxygen or more monitoring. Tracy Steerer from Johns Hopkins did a study in outpatients, finding again more likely sleep apnea patients might have a difficult intubation or need intra-op pressors, but there were no unplanned hospital admissions. Girish, in Anesthesia and Analgesia just last year, presented a nice overview. It was actually the Society for Ambulatory Anesthesia trying to produce guidelines for sleep apnea patients. And this is a complicated chart, but I can reduce it to a simple statement that although there were a number of, I will call, surrogate outcomes, things like decreased saturation or more oxygen needed, there were no harder outcomes, unplanned admissions, harder mortality, death, pneumonia, unplanned ICU stays. Kaw, in the British Journal of Anesthesia, did a meta-analysis, and they present these forest plots. And just look at the little diamonds in each of the areas, and you can see any cardiac event, a slight risk to sleep apnea patients, postoperative respiratory failure, slightly increased, post-op desaturation, post-op ICU transfer. Again, these surrogate outcomes are important, but how meaningful they are is not clear. This same group did a propensity analysis, taking a group of patients with sleep apnea and trying to match them to a group of patients that were similar in all other regards without sleep apnea, and again found things like ICU transfer. Finally, Bryson in the Canadian Journal of Anesthesia was unable to find an increase in the rate of unplanned admissions associated with sleep apnea. So this is not overwhelming evidence, certainly respiratory complications, desaturation, oxygen supplementation that are needed, but not a whole slew of other harder complications that we might worry about. And the last point I will make is that sleep apnea seems to be a risk factor for the development of postoperative delirium. This was a nice study published last year by Flink in anesthesiology, in which they looked at individuals with and without sleep apnea who had a total knee replacement, and about a 4 times incidence of delirium in the sleep apnea group. So again, emphasizing the relationship between sleep apnea and the central nervous system. So the reason I mentioned all these different studies looking at complications is one of the key questions is, if we have a patient with sleep apnea or suspected sleep apnea, should we delay their surgery, do a formal test, polysomnography, determine whether they have sleep apnea? If they have sleep apnea, put them on a course of CPAP. That's sort of the central question. And we have parts of it. We know that sleep apnea causes cardiovascular disease. We know that the treatment of sleep apnea can improve aspects of cardiovascular disease and general well-being of the patient. We have some evidence that suggests that sleep apnea can cause, I've used these words, surrogate outcomes, but not a lot of evidence that it increases myocardial infarction or causes the patients to spend a long time in the hospital or results in increased mortality. So I think it's been hard to convince the perioperative community that we should stop surgery, not do surgery, and proceed with a diagnosis and treatment. And I think, based on my discussions with many individuals, that the usual practice at most places is to proceed with surgery in patients. If they have sleep apnea, we might take special precautions, but it's unusual for us to cancel or delay surgery so we can do a formal diagnosis. Is severe sleep apnea a greater risk factor than mild sleep apnea? Again, if we're looking at these surrogate outcomes, the answer is yes. If we're looking at harder outcomes, death, excessive hospital length of stay, the answer is no. Does the perioperative risk depend on the type of anesthesia? Again, not a lot of information here. I think there are important interactions between the type of surgery and the type of anesthesia. Regional anesthesia may reduce some of the complications that I've shown related to how anesthetic agents influence neuromuscular control of the airway, but again, this has not been studied extensively. What should we do for patients with sleep apnea? The recommendations here are drawn from the ASA, had some perioperative guidelines based on expert consensus, not on hard data. Any drug that we use should be scrutinized carefully for the potential for causing respiratory compromise. If we can do nerve blocks or use local anesthesia, that's probably a good idea. Consider using CPAP during sedation, again, to try and prevent airway collapse. Certainly probably better to secure the airway than to do deep sedation in patients with sleep apnea. Obviously be prepared for difficult airway, those sorts of things. Completely have the patient completely awake when they're emerging from anesthesia. And you've heard me talk a couple of times about completely antagonizing neuromuscular blockade. Some of the things the ASA has emphasized as far as post-op management, simple things, again, residual anesthetics, opioids, et cetera, can cause respiratory compromise. NG tubes can decrease the caliber of the airway in the same way that we talked about excess adipose tissue or big tonsils, et cetera. So that could promote airway collapse. Again, opioid-sparing drugs such as non-steroidal anti-inflammatories, CPAP when possible. Now, as far as CPAP goes, there's been 2 studies looking at whether postoperative CPAP improves sleep disturbances and oxygenation. Drummond, 11 years ago, looked at 48 patients, not a big number, found that nasal CPAP did not improve oxygenation or episodes of desaturation. And more recently, O'Gorman, in fact, it's so recent it's just out in electronic form, many more patients, 138 patients randomized to CPAP or not, didn't show any benefit for the application of CPAP. And again, this emphasizes that it may just not be mechanical issues, it may be the neuromuscular control of the upper airway that is really the dominant feature postoperatively, and that influences whether obstruction occurs, and if that's the case, CPAP may be of less value. Where should surgery occur? I think this is, again, a controversial area, and I've listed in your handout a couple of protocols that have been proposed, including one by Samba that was just published this past year. And the bottom line for a lot of these things is sort of the same. If you have an individual whose sleep apnea is relatively controlled or controlled with a little bit of CPAP, and they have a kind of surgery that isn't too invasive and isn't painful, so they don't need a lot of narcotics postoperatively, and if they're relatively awake postoperatively and don't have episodes of desaturation, and or they can use their CPAP machine themselves, those are patients probably that don't need to be admitted and that potentially could go home. And on the other side of the spectrum, the more you have a patient with severe sleep apnea, higher amounts of CPAP that's needed, more painful or invasive surgery, a greater need for opioids, unable to manage their own airway postoperatively without assistance, more episodes of desaturation, those are individuals that probably need to be admitted. And so I'm going to leave it like that. I will also tell you that the ASA and other organizations certainly recommend that patients with sleep apnea be observed for a period of time after surgery, and that if they continue to desaturate, they be observed for an even longer period of time.